Virtually all women can use treatment for urogenital atrophy. Obviously, there are different treatment choices. Some women may choose to use vaginal moisturizers and lubricants, which are non-hormonal and no contraindication whatsoever. If women wish to use estrogen, which is the most logical treatment, then there are very, very few conditions which would contraindicate vaginal estrogen. The only situation where it is controversial is women who have a diagnosis of breast cancer and who are prescribed aromatase inhibitors. The opinion on that varies widely. I personally think it's counterintuitive to give somebody a drug to block estrogen and then give them estrogen. But other people will initiate vaginal estrogen early on in the treatment journey. And the reason for that is you get less absorption the healthier the vaginal mucosa is. And then we have different choices for vaginal estrogen, either estradiol or estriol, which is a weaker estrogen. So for women with hormone-dependent cancers, I think the logical choice is to use estriol. And that comes in a variety of different preparations, creams, pessaries, oily gel. And then there are the women who will have estradiol. That comes again in low dose, 10 micrograms daily for 2 weeks and then twice weekly. So for all of the estrogen products, there is a loading dose and then a maintenance dose, and the doses are very, very low. If women fail to respond to vaginal estrogen, then there are other treatment options, which include DHEA, which is a precursor hormone converted within the vaginal mucosa into estrogen and testosterone with minimal absorption. So that's another option. It has the additional benefit of local testosterone. But the other benefit with DHEA is that it is licensed to be used daily. It's marketed as Prasterone or Intrarosa, those are the trade names. And ospemifene is a completely different type of preparation. It's an oral medication, a selective estrogen receptor modulator, and that can be used in women who have had a diagnosis of breast cancer as long as they're not on active treatment. And then in future, we may be able to use laser therapy as an option. We still need to do randomized controlled trials with sham laser. But for women who've had hormone-dependent cancers, even if they're eligible for hormonal treatment, I think knowing that there is something coming potentially which has no hormones in it and therefore can have no increase in risk is encouraging. So in women who have non-hormone dependent cancers, they can access the same treatments for urogenital atrophy as we've just discussed already. So the lubricants and moisturizers, vaginal estrogen, either estradiol or estriol, which also has a loading dose of 2 to 3 weeks and then twice weekly maintenance therapy. DHEA, ospemifene, and potentially laser, all of those options are also available for women with non-hormone dependent cancers. The only thing I would say is if women have had radiotherapy and they have damage to the tissues, they don't always respond well to the recommended treatment choices for urogenital atrophy. Breast cancer is complicated. It's not just one thing. There are different types. There are estrogen receptor, progesterone receptor, HER2 positive cancers, triple negative cancer. So I think it's important that we collaborate with breast surgeons and oncologists. There are women who have a history of breast cancer with very severe menopausal symptoms in whom a decision jointly may be taken for them to use some form of HRT. But I don't think that's a decision that's sensible to be taken independently. I think it's really difficult when women have a diagnosis of breast cancer. They may be treated with medication which causes more severe menopausal symptoms than they would experience in a natural menopause. Initially, there's a lot of anxiety around the diagnosis. And then I think quite often low mood associated with a diagnosis. And it's only when women start to recover that they may think, could they still be eligible for treatment? One thing which I think is really important, if it's deemed not a good idea for women to have hormonal therapy, there are new drugs coming to market. They are at phase 3 clinical trials at the moment, neuroendocrine antagonists. There's 2, fezolinetant and elinzanetant. So I think there is light at the end of the tunnel for these women. Elinzanetant is due to be trialled in women with a diagnosis of breast cancer who are using either tamoxifen or aromatase inhibitors or GnRH analog injections, which basically shut down ovarian function altogether. And if women are not eligible currently, then there are some drugs which make a really big difference. Some of the antidepressants we use more frequently than others, partly because some antidepressants interact with tamoxifen. But drugs like venlafaxine and mirtazapine in very low dose work well for some women for hot flushes, night sweats, difficulty sleeping, and also have an impact on mood. What is important is that women don't think they're being given antidepressants because they're depressed. That's not why they're being given them. They're being given them to manage menopausal symptoms. So, for example, venlafaxine we use in a very, very low dose, 37.5 milligrams, in a slow release preparation to reduce side effects. And there's no additional benefit by increasing above 75 milligrams. And mirtazapine, actually, we tend to use in the lowest dose, which is 15 milligrams, because it has a better impact on sleep disturbance. So I think as long as women are told why they're being given medication, then they understand the rationale. And I'm always very clear with women, it's not because you're depressed. But we want women to feel as well as they can following recovery from breast cancer. And there are other drugs which are currently being trialled. Oxybutynin is licensed to be used for overactive bladder, and it can cause a very dry mouth, but it can also reduce sweat, so that may be a potential in future. And there are other drugs like gabapentin, pregabalin. They can have quite severe side effects, and it certainly isn't where I would go to first line. And then clonidine is an antihypertensive, but it's the only non-hormonal treatment which is licensed to treat hot flushes. So women with endometrial cancer can sometimes have HRT. It depends on the background. Was the endometrial cancer on a background of endometriosis? What's the grade and the stage? So it's important to collaborate with the gynae oncologist. And many of these women are treated with hysterectomy. Their ovaries are often removed, so they have a surgical menopause, which is more extreme often than a natural menopause. And if the grade and stage is low, then many of these women will benefit from HRT. It's different with different types of cancer of the womb. So that's where I think it is important to be very clear of the diagnosis. If it's a low grade and stage of endometrial cancer and the woman has been treated surgically, so her uterus and ovaries have been removed, she can be treated with estrogen alone. How she has that estrogen, whether it's oral or transdermal, a patch, gel, spray, to a certain extent is up to the patient. If the patient has a body mass index over 30, we would normally recommend transdermal delivery because that doesn't increase the risk of venous thromboembolism. But if the patient has a body mass index less than 30, then the choice is hers. Some of these women may need the addition of testosterone. And in that case, then the preferential route for estrogen is transdermal. In women who've had endometrial cancer, there is the potential for deposits of endometrial tissue to remain. And some people will use combined HRT, so estrogen with a progestogen. That has to be balanced against the slight impact of using both estrogen and a progestogen on the risk of breast cancer. Ovarian cancer is not just one thing. Most are epithelial tumours, and most of the time, women who've been managed surgically can have hormone replacement therapy, and most of the time that would be estrogen on its own, either oral or transdermal, patch, gel or spray. Sometimes women who've had a surgical menopause need implant insertion, but that would be a decision based on their response to other more readily available treatment options. There are some forms of ovarian cancer in which HRT is contraindicated. That includes germ cell tumours, clear cell cancers, and also borderline ovarian cancer. So in a patient with a history of an ovarian cancer, it's really important that there is collaboration with the gynae-oncologists and the oncologists to be absolutely clear whether there were estrogen receptors that were positive, progesterone receptors that were positive on that cancer that would potentially contraindicate HRT. For those women, if they're not eligible for HRT, they may have a significant improvement in symptoms with some of the prescribable non-hormonal alternative treatment options that we discussed earlier. And in the future, I think these women will be much better managed using the neuroendocrine antagonist drugs. Cervical cancer is caused by high-risk HPV. It's not a hormone-dependent cancer, and most women would be eligible for treatment with HRT. Women aren't always managed surgically, but some of the treatments that they have, whether that's chemotherapy or radiotherapy, can cause premature menopause, premature ovarian failure. So many of these women are very young, and it's important that they have HRT, not just for symptom control, but also to maintain their bone mineral density and to protect their cardiovascular health. And of course, it's not just about giving hormone therapy on its own, it's about making sure that women have as healthy a lifestyle as possible. Bladder cancer can be estrogen receptor positive, as can gastric cancer, actually. So I think some of the cancers which are not classically associated with hormones, we need to ask ourselves, is there a potential risk for this patient? The bladder cancers are usually managed by urologists, surgeons, and I think, again, we would want to make sure that there was some collaboration between the patient's urologist, oncologist, and anyone who was considering giving hormone replacement therapy. It depends how long ago the bladder cancer was, how aggressive that tumour was, and they tend to be more aggressive in younger women.